All right, well, we'll just go ahead and get started. We're a couple minutes behind, but so welcome to the 2025 Annual Opioid Settlement Community Meeting. So pretty much this meeting is for Caldwell County to hear input regarding our opioid settlement strategies. So just kind of a very brief, quick overview explaining a little bit more about this. So the previous NC Attorney General, Josh Stein, negotiated more than like $50 billion in national settlements with opioid companies. There's going to be multiple waves of that money coming in, and there's other trials as well. And that funding is projected to fund all the way through 2038. North Carolina, in regards to the North Carolina opioid settlement, they joined that agreement, and the NC Memorandum of Agreement, the NCMOA, was created. And that pretty much is between the state and local governments, pretty much the guidelines and directing the funds and the distributions of that. So these are just some links. If anybody wants to, if you don't know about these, you can write them down or whatever. But that's just so that way, if you want to learn more in detail about those settlements and the MOA itself. So we have identified, Caldwell County has identified 4 strategies: post-overdose response team, naloxone distribution, evidence-based addiction treatment, which also corresponds with medication-assisted treatment, and then our last one, recovery support services. I put an asterisk there because we are just adding that one. We did not get the funding for, Caldwell County did not get the funding for recovery court through the grant funding, so we added this into our MOA. So pretty much this is the next couple of slides is going to be our data, because all of these strategies are housed within Restart. So we have identified all of these strategies, and I'm going to let Jason, and of course he walks away at the most perfect time. Jason's going to talk a little bit about, I hit the wrong button. Jason's going to talk a little bit about the implementation of Restart and how it got started, as well as kind of up until this point, how Restart was started prior to the settlement funds and all of that.
Thank you. So I guess going back to what Sierra said as far as why we are here in front of you, again, back in 2021, the county, we got a grant that enabled us to enact this team, this Restart team. And that's where it began. It began with Gina, our original peer support specialist, and a linkage and a coordinator for that position, for that program and that grant. Towards the end of that funding, it was determined that the impacts that had been being made by Restart up until that point needed to continue. And then through that, and the sustainability of that original grant is where the county started to see the direction of what we can do and to expand upon that. And hence how the team was able to grow from 2 to those of us that you see here. We had a previous social worker as well, but she's left us, unfortunately. So that grant back in 20 and 21 got us up and going, and that grant was substance use disorder during COVID-19 for justice-involved individuals. Okay, so that was enabling us to actually start to get into the jail and start to see folks, to be able to make impacts there, to have peers like Gina go and talk to folks. How many people here are in recovery? First of all, congratulations. I need to acknowledge that in a space like this. Thank you, Donnie. Yes. So having that grant was the springboard for the county and to where we are now, and how we've grown to the team that we are.
Cool.
Good?
Yep, good. So we're just going to look into some of the data regarding what Restart does, along with the MOA strategies. Good Lord. So pretty self-explanatory slide here. We're going to be looking at 2023 versus 2024 comparisons. Our referrals from 2023 these are referrals that are referred to us, 394, and then in 2024 we had 516. That's a 31% increase of referrals. Just looking at a couple of these, specifically, I wanted to look a little more in depth with our criminal justice and our jail, and also the EMS. So initially, the criminal justice referrals, like he's kind of spoke to briefly, we started out kind of in the jail and just doing that. Whenever you're working with participants in the jail, you're reaching out to DAs, you're reaching out to probation officers, all that kind, people in that space. And because of that, I pretty much think that that's why we've grown our referrals like that. Like this is 234% from 2023 to 2024. Because I think those working relationships, people know us now, and we have people call us from the DA's office. We have probation officers who call us pretty much beforehand, so that way, instead of having to send somebody to jail, all of that stuff. And then also, we've had a judge call us, and while court was in session, to place somebody, and our peers were very successful in doing that. So another one is our EMS referrals. So as you can see on there, our EMS referrals have decreased. Just to define our EMS referrals, we have, those are overdose calls that come out that are dispatched as overdose calls, and as well as the referrals that are sent to us that maybe necessarily aren't overdoses, but there's some kind of substance use related situation. Our paramedics and EMTs on the truck identify that, and then they are able to send the referrals to us. So that's the makeup of that. Those decreased by 27% in 2024. So I really think that between our points of contact, our naloxone distribution, and our active engagement in the year of 2023 could possibly have a pretty good impact on the obvious decrease in our overdose calls in general, and then as far as all of the overdose calls in general, and all of our touch points and stuff. So we don't necessarily know that, but it's pretty obvious.
So this right here with this slide, how many of you were here for our sequential intercept mapping? What was the one entity that was in all spaces? Do you remember? Really? It was Restart. Who goes into the jail? Who's on the 911 calls? Who goes to the hospital? Who gets the referrals from DSS? Who gets the referrals from the hospital? Who gets the referrals from the justice system? Restart.
That's it. Okay, so our connections to resources, we talk about referrals, treatment referrals, but we also, that's not all that we do. We have referrals to obviously treatment, but then other referrals. Whenever we're dealing with participants, it's not just the substance use issue that we're wanting to help with. We all know that in helping somebody, those basic life needs help. To get stuff like that squared away, it only helps. So these referrals, just for clarification, these resources are not just treatment. This is all of our resources. So in 2023, you can see right there we had a total, we had a total of 394 participants in our program, and we were able to connect 131 of those to some sort of resource. And obviously the increase of 217% from the 2024 year of 516 total, and we connected 416 of those to some sort of resource. Okay, so our post-overdose response team, that's what we're identified as, and we are in a unique space being able to be a post-overdose response team under EMS. That pretty much gives us a very unique opportunity whenever, as far as post-overdose, someone has overdosed, 911 call. That moment is very vulnerable for people, and that is a vital, that's very vital to our team's impact. That touch point is incredibly vital. What you're looking at here is the comparison between 2023 and 2024. This is something that we've done essentially from the beginning, which is our overdose mapping. I didn't take the time to map out perfectly the county, but you can kind of see the counties in there, and all those dots are inside of the county. These are overdose calls that naloxone has been administered. We obviously get other calls as overdose, but they're not opioid overdose calls. But these documented are the calls that if something wasn't done, it's possible that these individuals would die. So in 2023, 228 of those. And then we had 14 suspected overdose deaths. And then in 2024, those calls were 158 with 8 suspected overdose deaths. That's a 30% decrease in those calls. Another strategy is our naloxone distribution. We had a small decrease in our distribution. We went from 475 doses in 2023 to 463 doses in 2024. However, even though we had a small decrease in that section, we had a huge increase in education opportunities in the year 2024. We identified that larger scale naloxone trainings and education needed to be done within the county, and we implemented those thoughts and those, when we identified all that, we implemented that in the year 2024. We've done a lot of trainings. We've done community trainings that was at the public library, open to the community. We have trained quite a few different workplaces, and we've supplied them as well with naloxone, MDI being one of them. We've trained some of the law enforcement agencies within the county. All county employees have been trained, and then we are currently playing a pretty big role in the development of naloxone availability in the Caldwell County school system, in the public schools. And that's going to, prior to that implementation, that's going to result in the training and education with their MERT team and stuff like that as well. You grab the mic. Do you have anything else? No? Okay, so our last strategy is the evidence-based addiction treatment, which correlates to our medication-assisted treatment. So for definition, most of y'all probably know, but medication-assisted treatment is the use of medication in combination with counseling and for the treatment of substance use disorders. So this protocol that Jason helped, and Dr. McClinton and Snyder write, went to the state, and that was approved about mid-2023. We identified our first in possible induction in 2024. And so our field inductions since then, or for the year 2024, has been 3, and we done one just the other week. But then we also have facilities like RHA, and we have virtual things, virtual partners, and ICGH. They also do the medication-assisted treatment, and those some on a case-by-case basis, we either could do it ourselves or, depending on the situation, can refer them out. Those referrals out to the MAT treatment specifically, those were 27 in the year 2024. 2023 is not on here just for the simple fact of our protocol wasn't made until halfway.
This specific strategy is one that has been on our radar. Dr. Bujol knows this for quite a long time. Not only here, being able to get it out into the public, but also into our jail. This is tough to be able to do in the field. The numbers are very low. Does anybody have any idea maybe why? Anybody in recovery works in the space might be able to talk to us a little bit about maybe why this is a lower number. As I'm looking at my RHA people, they're keeping their lips nice and tight. So there's a lot of different reasons for this, but the unfortunate part is people that use drugs use the medication that we use the incorrect way, right? What would you say? You mean they abuse it? Okay, so they're the medicines that we use to induct and do this is Suboxone and buprenorphine. That medicine is unfortunately used on the streets to bridge from high to high. It gets them sick when it's not used appropriately at the right timing, right? Anybody in the MAT space understands that and knows that. And so it's very difficult for when you have Nathan come out on a 911 call, has a naloxone wake up, someone's now there, and we're like, hey, can we help you feel better? There's this medicine that we can help you with. Well, they just used 3 days ago, and they just used that medicine and got themselves, unfortunately, that precipitated that withdrawal. Right, Angel? Right? So this is a medicine that needs to be done by paramedics, physicians that can do it appropriately. Unfortunately, it does get abused. It can get abused. But that's why this number is so low, but it is evidence-based. It can help. And Dr. Bujol could speak to that for days if we let him. But that's why I wanted to speak to that lower number that we see at times.
So as far as the statistics go and what Restart is doing with the strategies, that's pretty much it. With all of them, with all the strategies being housed in EMS, within Restart, we really appreciate you guys coming and listening to us. And I guess at this point, we'll open it up for any comments or questions.
I got the mic. I'm coming to you. Doc. If you could, when you do get the mic, if you could just say your name and identify, like if you're with an organization too.
So oops.
Never mind, he's going to break the mic. First one. There we go.
So I'm Dr. Bujol. I'm a family physician. I've practiced in Caldwell County for almost 40 years. And I was going to ask Jason maybe, or if you want me to do it, talk about this database that we're creating it's called Goldie. Do you want to talk about that?
Talk a little bit to it. Yeah.
Okay.
Now?
Yeah.
Doc, I gave it to you. You're supposed
All
to
right.
keep
Well,
it.
all right. All right. I'll talk about it then. So, all right. Thank you. I've always said, you can't correct a problem unless you've got data, and we didn't have any data about. We still don't know how many narcotic addicts we have in the county. You know, we've got probably at least 500 from the data you presented. I mean, I thought that was a lot, but I think there's probably a lot more. So we were in the process of looking for somebody to help us create a database, and it's turned out that somebody from the Eshelman School of Pharmacy at the University of North Carolina was of the same mindset as we were, and they were already well on their way to creating this database that was HIPAA compliant, and it was available via an app either on an iPad or an iPhone. And so the peer support team can come out with their iPhone or iPad when they're on a run, and they can enter people into this database. And it does the usual demographic stuff. You know, how old are you? Do you have any other medical problems? Where do you live? But the unique thing about it is also looks at all the social determinants of health. So you interview one of these people that they've got out on a run from, and you know, you can find out things like, do you have hepatitis C? You know, do you have HIV infection? And have you been treated? And if you haven't been treated, maybe we can find somebody to help you treat those things. And then, are you living under a bridge? You know, do you have food insecurities? Well, we can help you, you know, connect. You know, you mentioned all these resources that you referred people to. And eventually, the people that have Goldie can look up anybody that they come in contact with, and they'll have a lot of information, which then they can, again, you know, they can measure things and then they can act on what they've measured. We're one of 3 counties in the state of North Carolina that's piloting this software out in the field. So it's still a work in progress, but I think it's going to really help us to kind of get a handle on this. And I've always said, you know, you always talk about it takes a village to raise a child, and it's going to take a village to fix this problem. And it's going to take a lot of disciplines. It's already started. I don't know if you want to add anything to that.
Giving it back and forth. Yes, thanks, Doc, for that. So yes, the data and the information that we're able to collect as that overdose response team and through Goldie is all information that has to be reported on to the state for the very reason that why we're here today. That's information and data that they're asking for, that they need to see and hear. So this system is able to collect that, neatly put it together, be able to, and for us to be able to report as a county back to the state. So it's extremely beneficial. These guys, we've had a little bit of headaches with, you know, change is difficult for any of us, especially in emergency services. You know, we changed documentation system, it's going to be a pain. If they changed Epic at the hospital, I bet you'd have a lot of upset nurses, right? So with anything, but growth is happening. Thanks for that, Doc. That's 100%, yes, sir, it is. We're actually in the alpha phase of that.
What's our efficiency rate right now, do you think?
Efficiency of what? Of using it?
Yeah, like you were talking about. We use it every day.
We use it every single day on every single interaction that we have.
So we're 100%, every overdose, everything we have is going into the system.
Since November.
100% since November.
November 6th, we've used it.
Well, you were talking about change. I know sometimes change takes a little while.
It does, yep, exactly.
Low at the beginning.
Yep, exactly. Yes, ma'am. Hang on.
Who all has availability to that app?
Just us right now, just us, yes. Hopefully hospital systems and in the future to be able to, you You know, again, because it's HIPAA compliant information and such. Yep. Yeah.
I just wanted to add to the conversation for Goldie. Oh, my name is Alicia Stanislaw. I'm a nurse at UNC Health Caldwell, but I'm the service line director for psychiatry, women's health, and children. And we have been collaborating with Restart and county management to look at the integration of Goldie as a case management electronic medical record system that Restart is using, and interface it and integrate it into Epic at UNC Health Caldwell. That way, when there is a patient that Restart is working with and they are seen within the UNC Health Caldwell footprint, there would be an interface of information sharing so that patients who are seen can have that seamless continuum of care. We've done a report, we've done a strength assessment and recommendation at a UNC Health level, and they're looking at the architectural review of Goldie and to see if that interface could occur. But there is a cost and a licensure fee, and it's something we're hoping that the county would consider looking at further to investigate that financial investment. But we're very supportive of that integration. But there will need to be some funds that will need to be secured in order for that to happen. But we are looking at that from an architectural review, and in the couple of weeks to come and months to come, we'd like to explore that opportunity at a county level. Thanks, Jason.
Thank you. Who's this? Who's this now?
I'm Donnie Potter, one of the county commissioners here in Caldwell County, so I was just kind of curious of why Alicia was looking at me during the whole time she's talking about funding. It's amazing how that happens, isn't it?
If there is one.
I'm just kidding.
Thanks, Commissioner Potter. Yes, ma'am. We got to do the mics.
Hey,
'cause
Tracy, if I
Eric's
had
back
to, you
here.
have
He's
to.
like all over it. He's like, you know.
Tracy Irvine from RHA. Given the current funding that is available and the longevity of that funding, does the county have plans at this point to expand, Restart, or other programming with the funding that is available?
It's a very good question. A very good question. We are taking notes as we do that right now. Currently, again, these strategies are through fiscal year. So those discussions are going to be upcoming to see, and hence why we're here today. Yep. Yeah, that was part of it. Yeah.
I think we will be expanding it because we'll start paying for recovery for that coordinator.
Hang on. You got to talk into the mic, Crystal, or else it doesn't count. Eric's back. I know.
So Crystal Henderson, Caldwell DSS, and just a question. I noticed that last year you guys had about 400 folks that you connected to some type of a resource. Do you track, like a year later, or any kind of like a follow-up on that, like where are those folks at going down the road? Like how many of that 400 are still connected to a resource? How many are in recovery, or how many can't we find, or that type of thing?
So pretty much that's the goal. However, as far as they're not engaged anymore, you can't reach them. But yeah, absolutely. If we can follow up at that time frame and do our assessments at that time frame, absolutely, yeah. But unfortunately,
That's one of
sometimes
the huge points of Goldie and what it's able to do to be able to do that. So end game, end goal, large, 5,000 foot view down the road. What they're being able to do is if Jason was to move to Carteret County and go and I overdosed there, and Carteret County uses Goldie and they're there in that specific area, or if they go to the hospital there and it's in the Epic system, that person will be flagged and noted, and then that's somebody that's that continuation of care, so that we're able to know that. But as far as the assessments and the follow-ups, again, as long as they're engaged with us, as long as we can continue to remain in contact with them, 100%. And that's where this particular program is so beneficial with that. Any other thoughts, questions, concerns, comments? Angela, you want to say anything? Are you on there?
I see what it is you're worried because you heard Dr. Bajol talking about sharing the system. Nobody has access to the system and anybody that we put in there.
But like,
But,
Correct.
as far as like, cause I mean, I can't remember the last time I OD'd, but it's been like a long time ago, cause I've been sober for almost a year.
Correct. It's all protected health information.
But is it, how far back does it go?
It does not go back that far.
I'm just curious,
Yeah.
'cause like now I'm just like, okay, so I know that it's HIPAA, but a lot of people, if I'm being honest, a lot of people don't follow HIPAA. Especially, you know, I've been to a few hospitals, they don't follow it. But, I don't know, I just, well, there's some questions.
Understood.
I don't know.
Glad you're here. Glad you're all here. Thank you for coming. Again, I'll keep it open. Anybody have any questions, thoughts, concerns? If not, I guess we will adjourn unless Sierra's got anything else.
I'm all talked out, bud.
You're all talked out. She's all talked out. I'm going to remember that. All right, well, thanks for coming.
Yep, thank you.
Thank you.